Good afternoon, Dr. Mishra. You can start with your topic.
Respected Chairperson, Dr. Ghosh, Co-Chairperson, Dr. Pal, respected Dr. P.C. Rai, my seniors, friends. Okay. Friends, my topic is management of tuberculosis, Indian guidelines. Tuberculosis management, I think most of us know. As you must be remembering the famous film Munna Bhai MBBS. Munna Bhai remembers the 4 drugs that is given in intensive phase and 2 drugs in the continuous phase. So when Munna Bhai knows, we must be knowing. So, but what is the reason of my presenting this topic? It is to know the challenges that we are encountering now and what are the mainly the challenges and the new developments. So, as you all know, tuberculosis is an infectious disease caused by Mycobacterium tuberculosis complex, which usually affects lungs, although other organs are affected in 1/3 of cases. Transmission usually takes place through the airborne spread of droplet nuclei, which is coughed by a patient of pulmonary tuberculosis, and the nuclei size is less than 5 micron. Burden of TB. You must be astonished to know that 1/3 of world population are infected, and out of every infected person, 10% will develop live disease in their lifetime. India accounts to 20% of global TB burden, roughly 2.2 million patients. About 3 lakh people die every year, which is about 2 patients every 3 minutes. 66,000 new cases of multi-drug resistant TB are recognized every year. Continuing with problems in India, roughly 2 million new cases are detected annually. 0.8 million cases are smear positive. 75 nearly smear positive per lakh population are seen. Estimated prevalence, 3.8 million bacillary cases in 2000. This is old data. And the mortality is roughly 3.3 lakh death due to TB each year. As I told you, almost 2 deaths every 3 minutes. Prevalence of TB infection, 40% of people in India are infected with tuberculosis, which will develop tuberculosis disease in 10% of cases. The estimated TB multi-drug resistant is about 3% in new cases and 12% in retreatment cases. And what is the relation of TB and HIV? 2.31 million people living with HIV infection, 10 to 15% of annual risk, and about 5% of TB patients are HIV infected. And what is the picture of women in India? More than 50% of female patients suffer before the age of 34. More than 1 lakh women are abandoned by the family because of tuberculosis. It accounts for 1/3 of female infertility. And TB kills more women in reproductive age group than all causes of maternal mortality. So, how will you diagnose tuberculosis? The cornerstone of diagnosis is sputum smear examination. And there are about 13,000 microscopic centers all over the country. Sputum culture and drug susceptible testing to detect MDR-TB, chest X-ray and histopathological examination, particularly for extrapulmonary tuberculosis. Sputum smear examination. Sputum is examined after staining with Jaden staining or fluorescent Oramin stain. It has a good specificity, means TB bacilli identified means it's a case of tuberculosis, but it's a low sensitivity because many patients, they do not produce AFB, like children, like who are non-cavitary pulmonary tuberculosis patients, and people with HIV infection, they do not produce sputum AFB. This is a picture showing sputum AFB in Zn staining. Sputum culture. It is more sensitive than microscopy, but the problem is it takes 4 to 6 weeks. So what are the indications? To diagnose possibacillary cases where we do not find AFB, drug susceptible testing in all previously treated patients and people with high risk of MDR TB. X-ray chest, pulmonary tuberculosis is often suspected. A patient coming to our OPD and we advise a chest X-ray, and if there are lesions, we suspect the probably patient is suffering from tuberculosis. Though upper lobe cavitation and infiltration are classic picture, but any pattern can be possible. And in era of AIDS, any pattern can be seen. Chest X-ray, but remember, chest X-ray never confirms whether the TB is active or not. Here, a patient, a smoker, 70-year-old male, came to our OPD with this sort of history of cough and fever. This was the chest X-ray. We repeated sputum maybe twice, it was negative. But you can find there is a cavity in the left mid-zone and infiltration in the upper lobe. Depending on the chest X-ray, we started ATT. Here is a patient, young boy, 16-year-old young boy, presented with cough and fever. You see the lesion. There is haziness in the mid-zone, and sputum AB was positive. We started antitubercular treatment, category 1, and this was a chest X-ray after 6 months. Mantoux test. It has limited value in an endemic country like ours. Positive test indicates infection, but not the disease. It shows hypersensitivity to proteins of TB bacilli, or due to infection, or due to vaccination. It is helpful, but it is helpful in diagnosing children suffering from TB. ADA, an enzyme found in most cells, particularly neutrophils, it is elevated in tubercular pleural effusion. It may be helpful in confirming the cause of death, cause of effusion. WHO has strongly recommended that serological tests, like many people advise TB, IgM and IgG, the serological should not be used to diagnose tuberculosis infection. Now, what is GeneXpert? GeneXpert is a new test started recently. It detects microtuberculosis in just 90 minutes. It is very sensitive. As you can see, it can detect 131 colony forming unit per ml of sputum in compared to 10,000 colony forming unit in sputum microscopy. The principle is it is actually a nucleic acid amplification test that uses a disposable cartridge with GeneXpert instrument. The sputum is mixed with reagent and placed into the machine, and the gene is detected. It not only detects TB gene, but also detects resistance to drug like rifampicin. But please remember, it does not replace sputum microscopy. Regardless of the result, the sputum should be subjected to drug susceptibility testing. Now, coming to the algorithm of how we approach a patient of cough. A patient with cough for more than 2 weeks, subject the patient for sputum smear examination. If positive, start ATT. If two tests done negative, give antibiotic for 10 to 14 days. But my friends, please remember, don't give quinolones, because quinolones also act against tuberculosis. So don't give quinolones. You can give amoxicillin or augmentin. And if cough persists, repeat sputum examination after 2 weeks. If positive, start ATT. If two negative again, do a chest X-ray. Chest X-ray suggestive of tuberculosis, like the X-ray I showed you first, start ATT. And if negative, it is non-tubercular. Now coming to treatment of tuberculosis. What is the goal? To ensure high cure rates, prevent emergence of drug resistance, minimize relapses, and cut the chain of transmission through early diagnosis and treatment. The regimen, as I have already told, intensive phase, which consists of giving 4 drugs, and continuation phase, we give 2 drugs for 4 months. Intermittent administration 3 times a week allows supervision to be carried out by the second person, which is the principle of DOTS. regimen for previously treated cases. A patient, what is a case previously treated? Means a patient who has taken treatment but has left. So, left more than 1 month or more than that, and again has come to you. What will you do? In this case, you do intensive phase, you give 5 drugs instead of 4, means you add streptomycin. And the intensive phase should be continued for 3 months. Like I have shown, 2 months you give 5 drugs and 1 month you give 4 drugs. And continuation phase, instead of 4 months in simple cases, here the continuous phase is for 5 months. That means the total duration becomes 8 months. Treatment monitoring. This is the golden principle. This is the most important principle of DOTS. You should examine the sputum after 2 months and completion of the treatment. Chest X-ray is not recommended for monitoring the treatment. Now coming to extrapulmonary tuberculosis. Treatment varies. If it is a case of simple case of lymph node tuberculosis, you give treatment for 6 months. But if it is, say, affected the bones, meninges, or pericardium, you give for 9 months. And steroids are helpful in pericardial and meningeal tuberculosis. Ethambutol is replaced by streptomycin in TB meningitis. Pregnancy. Streptomycin is contraindicated in pregnancy. Breastfeeding can be continued if mother is on treatment. Mother should practice cough hygiene. Child should be given chemoprophylaxis with INH. Now coming to the major challenges in TB control. Poor health care infrastructure, like in villages, poor choice of investigation and drugs by private doctors. You must be knowing that many of the private doctors, they do not follow this guidelines by Ntpc, or they do not follow the DOTS. And HIV infection, they advise a lot of tests like CT and all that. HIV infection, poor drug compliance, ignorance, emergence of MDR-TB, and lack of political will. Here, a patient I am showing, this patient left treatment and has gone to a private practitioner. After almost 1 year of, he received treatment for 2 months, he felt improvement and he left. Then after some time, he developed cough with hemoptysis and he went to a private practitioner. What has happened? Here you can see a prescription. Here the doctor has given all sorts of treatment, advice, and he has also noticed that there is fibrosis in the, just see fibrosis in the X-ray, but he has failed to advise a sputum A-B, and he has given all sorts of treatment. He came to us and we saw there were plenty of sputum A-B, and we started a TT. Now coming to HIV and TB. Co-infection with HIV and TB, these people are 20 to 40 times more chance of developing TB. TB is the leading cause of death with HIV infection. Tuberculosis accelerates HIV disease progression. TB increases HIV infectivity and reduces treatment efficacy. Co-infection leads to rapid development of MDR-TB. What is MDR-TB? MDR stands for multi-drug resistant TB. Is a strain that is resistant to isoniazid and rifampicin with or without resistance to other drugs. And what is XDR-TB? An extensively resistant tuberculosis is a strain that is resistant to at least isoniazid, rifampicin, a quinolone, and a second line injectable, and TB drugs like aminoglycoside like amikacin, kanamycin, or caprimycin. See the level of resistance. So what are the factors for drug? Why people develop resistance? That is inadequate treatment or ineffective treatment. People interrupt, they take treatment for 2 months and feel well, then leave. Ignorance, poverty, this is a very important factor. People do not have money, they don't know about the DOTS. Delay in identification and susceptibility testing. We do not do a culture, and massive bacillary load. Importance of drug resistant TB. What happens if a patient suffers from drug resistance? They do not respond to standard TB regimen. Time of treatment may last 2 to more years. Drugs are less potent. The drugs that we give are less potent, but more toxic. And close contacts who come across with the people of suffering from MDR-TB, they are also infected with drug resistant TB. Where MDR to suspect. all patients who have failed first-line treatment, all previously treated patients, all HIV, TB co-infected patients, any smear positive follow-up, new or previously treated patients, all pulmonary tuberculosis patients who were contact with MDR-TB. So now, what will you do if a patient you are suspecting MDR-TB? In intensive phase, we give 6 months these drugs, kanamycin. I have already told that MDR-TB are resistant to INH and rifampicin. So intensive phase, we give kanamycin, levofloxacin, ethionamide, pyrazinamide, ethambutol, and cycloserine. In continuous phase, we last for 18 months, we give levofloxacin, ethionamide, ethambutol, and cycloserine. Regimen for XDR-TB. This 6 months regimen becomes, there are 7 drugs. These are the drugs. And continuation phase, we give 6 drugs. So how to prevent? DOTS is the best option. The key to successful prevention of emergence of drug resistance is adequate case finding from diagnosis and effective treatment of infected patient. This can be achieved through DOTS. DOTS approach consists of case detection by sputum microscopy, culture and drug sensitivity testing, administration of short course chemotherapy under supervision, monitoring and evaluation with impact management, effective drug supply and management system, political commitment, and increased sustained financing. What is DOTS plus? This started by WHO in 2000. It refers to the MDR-TB diagnosis and management treatment. The goal of DOTS plus is to prevent further development of and spread of MDR-TB. Treatment, what is treatment failure? Failure is said to be present when sputum, smear, or culture remain positive after 3 months of treatment. If patient condition is deteriorating and culture report is awaited, give 2 more drugs, 2 new drugs which have never been used, and complete the treatment after the culture report is available. What is relapse? Relapse is defined as a patient who experiences a recurrence after successful treatment. The treatment is 5 drugs. Start treatment with 5 drugs until the culture report is available. RNTCP. RNTCP is a government national program, and it was started in 1997. The entire nation was covered in 2006, and the program of DOTS, they use the program DOTS, and it has covered 1 billion people in 632 districts. What is the initial objective? The objective was to detect cases in at least 70% and to achieve TB success, treatment success in at least 85%. The impact of RNTCP. By using DOTS, you can see the first is pre-short course chemotherapy area, second is short course chemotherapy area, and third is RNTCP area. You can see very well that the cases has gradually come down, and after seeing the success of RNTCP, the targets are again revised. What are the revised target? That 90% case detection. We will do a 90% case detection, and including people affected with HIV. Initial screening of all previously treated smear positive TB patients with drug resistant TB. We will screen all these patients with sputum culture, and we will link HIV infection, HIV infected TB patients, and HIV care. We will also give those who are HIV patients, we will give care, we will treat them. Successful treatment of at least 90%. And not only that, the revised target also says that RNTCP should be extended to all the private practitioners. So, achievement of DOT. So, what is the achievement? Achievement 80%. Our initial aim was 85%, but we have achieved 87% success rate. So, DOT story is a success story. Reducing case fatality 7% to 4%, and in India the success is 29% to 4%. We have averted 6 million deaths. It is not a joke, and curing 36 million patients. 11 million patients are still on treatment in India. And what is Stop TB strategy? It is launched by WHO in 2006 to be implemented over 10 years and to last till 2015. The target is to reduce the prevalence to 150 and reducing death to 15 per lakh. Components of Stop TB strategy: pursuing high quality DOTS expansion and enhancement, addressing TB and HIV and MDR-TB, contributing to health system strengthening, engaging all care providers, empowering people with TB and community, enabling and promoting research. BCG vaccination. Vaccination is routinely recommended at birth in countries like India. Not recommended in children with HIV infection. It induces tuberculosis sensitivity reactivity, which tends to wane with time. The presence of size of TST reaction after vaccination doesn't predict the degree of protection. So, to the summary, what we have discussed, TB is a chronic infectious disease caused by Mycobacterium tuberculosis. Quick diagnosis and treatment with available drugs cure most cases. Poor compliance of patients, emergence of drug resistance, and HIV co-infection are challenges that has eluded a TB cure in spite of available good drugs. So, providing good quality drugs will not only cure a patient but also prevent emergence of drug resistance. People with HIV co-infection should also receive antiretroviral treatment. Finally, factors like unhygienic living condition, poverty, malnutrition should be addressed to eliminate TB. This is the DOTS program in our hospital. Gradually, the number of cases have increased, and presently, in this year, there are 127 patients have been registered, and 8 patients are sputum positive, 7 were extrapulmonary. Stop TB by using DOTS and save the world.